Welcome to Inpatient Update. I'm your host, Mason Turner, and this is the podcast for practice-changing evidence for the working hospitalist. Today on our show, I will discuss early beta blocker use in cirrhosis, doing half-dose Eliquis for folks with cancer-associated clots, and prophylactic antibiotics in patients with biliary obstruction. So, I'll start off with introductions, as this is the pilot first episode of my podcast. As I said, my name is Mason Turner. I'm an early to mid-career hospitalist. I'm board certified in internal medicine. I practice at a major academic medical center in the Southeast, a tertiary referral center. I practice both direct patient care as well as working with teaching services and learners. I started this podcast because this was something that I wanted. This was a podcast that I had hoped and wished was already out there, and so I decided to make it be so. This came about because I, as I presume a lot of the listeners will, really valued being up to date with my medicine. I've always never wanted to become that hospitalist that you read a discharge summary from an outside hospital and you think, man, this provider's practicing 10, 15-year-old medicine, not following up-to-date guidelines, not following up-to-date data. And but it's harder said than done. And the further I've gone through my career, the more and more difficult it's been to stay up to date. And that's particularly between being busy clinically along with busy with other things in my life. I'm a husband, a father. I have other responsibilities, other obligations, other interests. And all of that makes it really hard to stay up to date on the literature. I've gotten the mailers in my mailbox every 2 weeks or whatever that give me all the up-to-date articles. And a review of articles in my field, but honestly have not been able to consistently sit down and read them. And if I miss a couple, then I feel like I'm out of date and missing a major part of what is pertinent in the literature out there that could affect my practice and could help my patients. So because that's been so hard, I thought about it, and one thing that I feel like I can keep up with is my podcast feed. And so I hunted for a podcast that would fill that same void. And the only podcasts I found were either long format internal medicine podcasts on a specific topic, not necessarily keeping up to date on the literature, or were someone reading general highlights from a particular journal in a monotone way, just reading through, that I found frankly unlistenable. So what I decided to do was make a podcast. So Inpatient Update. The idea, the guiding principles are kind of threefold. And one is that it's efficient, short, listenable. Goal, about 20 minutes, the time it will take you to do your commute, walk your dog, wash your dishes. Number two, it's pertinent. And so I'm a working hospitalist. The articles that I choose to highlight are things that I think I can use with my patients on a daily, weekly, or monthly basis regularly. And then three, trying to make it listenable. The scripted format where someone just reads, I find really difficult to really engage in. And so in the future, I will have co-hosts with me, guests or regular co-hosts, that we can have a discussion to really make it listenable, give kind of that parasocial to help really make it an engaging podcast to listen to. So with all that being said, I'll get into it. Again, want to be efficient and go through a few articles that I found interesting in the literature. The first one we'll go with is antibiotics for prophylaxis before ERCP and biliary obstruction. if your institution is anything like mine, you perform ERCPs. And because of that, patients come from far and wide to get those ERCPs. There seems to be a dearth in my state of providers that perform these RCPs, and the ones that do, having the skill and the instruments to do them successfully, consistently. And so we very often transfer people from outside hospitals to get ERCPs. The holidays were here recently, and our GI suite was down for anything other than emergencies for days on end around Christmas time. And then I was on call working that Sunday before that work week after the Christmas holiday came back, and we brought in, I don't know how many different patients from outside hospitals to get an ERCP. And you know the patient, bilirubin anywhere from 2-ish to 20, normal vital signs, maybe a tad of a bump in a white count, but no fever, negative blood cultures, and then imaging shows biliary obstruction, a stone, malignancy, what have you. But they're not clearly infected. And I'm constantly having the question of, do I throw antibiotics at these people or do I not throw antibiotics at these people? So there was a recent, in November, in the Journal of Clinical Gastroenterology, and I'll put a link in the show notes, but an article entitled Antibiotic Prophylaxis Before ERCP for Biliary Obstruction. It was a meta-analysis that entailed in total 2,100 patients from 11 different randomized controlled trials. And it looked at prophylactic antibiotics versus no. And these are in patients that, again, didn't have any clear indication of infection coming in, but did have biliary obstruction. And it showed that there was significantly improved outcomes in the folks that got antibiotics. So less infection, 2% versus 11%, with a number needed to treat of 12. Bacteremia rates were lower, statistically significant. And the most common antibiotic used in all of these cases was cephalosporin. So highlight I took from this is that all of these patients coming in after a weekend, after the holidays, who are backlog of ERCPs from other institutions that aren't able to provide them, I'm giving them at least one dose of a cephalosporin before they go to ERCP, hopefully the next day. And then from there, basing things on what my gastroenterology colleagues think about how significant the concern was for infection based on the procedure. And now this recommendation for this dose of antibiotics is whether or not my colleagues think they've got good drainage. Even if they've got good drainage with an ERCP and a stent and a sphincterotomy, it was still shown that antibiotics were overall helpful. All right, the next study I looked at was regarding extended reduced dose Apixaban for cancer-associated venous thromboembolism. And now this is a case or a study that in my practice honestly has influenced me more in making me realize why other providers are doing what they're doing. They were probably more up to date than I am, rather than anything that has actively changed my practice yet. But this was an article from March, New England Journal of Medicine, looked at 1,766 patients, was a non-inferiority trial in patients with a cancer diagnosis along with a proximal DVT or a PE. And so they all got an initial 6 months of treatment of Eliquis, presumably with the 10 milligram load, and then going to 5 milligrams forward from there. But then after those 6 months, patients in the treatment group and the intervention group were dropped down to 2.5 milligrams BID. And the primary outcome they looked at was recurrent DVT. And the subhazard ratio was 0.65, 95% confidence interval crossed 1, and so was indicative of non-inferiority. And then the bleed rate was less, and that was statistically significant with the confidence interval 0.58 to 0.97. And so for me, I'd been seeing more and more this 2.5 milligrams BID Eliquis being used in patients. And as we know, all the initial guidelines and studies for this was that half dose. Eliquis was specifically for folks AFib with stroke risk reduction and meeting 2 of the 3 criteria of age, weight, and renal function. But I was seeing this constantly in these other patients, and I frankly admitted someone who had multiple myeloma and came in and did have a significant PE and was on this 2.5 milligram dose. And I'm talking to my residents about how that's not the correct dose and that we don't dose reduce in patients who have cancer. But probably my presumably board certified hematologist in the hemonc department who was treating this gentleman with multiple melanoma knew about this data that it's shown in the aggregate to be non-inferior. And so I've been agreeable to using this 2.5 milligram dosing more because the data, at least in these cancer patients, backs it up that it's non-inferior when it's related to clots and has less risk of bleeding. Next and last, should we start beta blocker prophylaxis earlier in patients with cirrhosis? This was from a July article from the American Journal of Gastroenterology. It was a study from India with 104 patients with cirrhosis with new uncomplicated ascites. It was a randomized but open label, study. And at 1 year, there was shown less ascites-associated complications. I got really excited about this article when I saw it in my little up-to-date article roundups literature that I mentioned earlier, because I clearly saw how it could change my practice, that instead of waiting until folks have varices on EGD, instead we are going ahead and starting them on a beta blocker, reduce the risk of esophageal variceal bleed at the first onset of ascites. Now, when I first read this article, I had a patient that I was dealing with on wards, and I was rounding with the teaching team, and it was a patient who came in with SBP, spontaneous bacterial peritonitis, and new cirrhotic first instance of ascites. And I said, all right, as we're going through the things we need to do for this patient with new cirrhosis, what do we need to do to risk reduce them? How can we take this hospitalization for this patient and improve her outcomes going into the future? And so I mentioned this article that showed value in starting beta blockers earlier. But I will point out, as I said, this is new uncomplicated ascites. And my pharmacist working with me pointed that out, and we talked a little bit about the concept of a window of opportunity when it comes to treating prophylactically cirrhotic patients with a beta blocker, that once they have complicated ascites, the guidelines are no longer to treat them. So it does not change that portion. My patient had SBP because of the infected ascites. She basically would not have met the criteria to look at for this study. She would have been in the exclusion criteria. What it does essentially is just opens that window earlier than it did before, making that window larger. That and looking back at it, was really a pretty narrow window where you've got esophageal varices, moderate esophageal to severe esophageal varices on an EGD, but you don't have any complications from ascites, which is really a pretty small window. And so opening that window sooner, that anyone, whether they've got small varices, whether they've got no varices, whether we've never looked for varices, and starting them on carvedilol at a prophylactic dose being beneficial, is significant. It's going to change. It's changing my practice already. There's been other patients that I have been able to start that beta blocker on, and the outcomes were pretty significant. There was significantly fewer large volume paracenteses needed between the groups, 27% on the beta blocker group versus 58% in the non-beta blocker group. So a number needed to treat of 3. Ascites was resolved more likely. There were fewer deaths with a number needed to treat of 6. So really impressive data that is having genuine improvement in patient outcomes. Very specific use case. So be cautious like I did and make sure that this patient actually is in the window. But when you get these patients with new ascites, think, let's start them on a beta blocker unless they have some complication to their ascites. Those are my 3 articles for today. Again, wanted to keep it short, so I'll end there. I hope you enjoyed the podcast. Thank you for joining me today. If you have any comments, please put comments on wherever you're listening to this podcast. If you have ideas of articles that I should review on the podcast, let me know. If you'd like to be on the podcast and join me as a co-host or a guest, please let me know. Reach out. You can find me on the website. You can leave a comment, send me an email, find Inpatient Update on Instagram. So this has been Inpatient Update. Thank you for joining me. Goodbye.